guys, Vic Gatto. I have a great Healthstorm episode today. Dave Johnson, he's the CEO and founder of Foresight Health. It is an advisory, consultancy, and platform to teach people about the healthcare revolution that's coming to the U.S. It's a great conversation. We talk through all things healthcare and the revolution that's coming, what I normally call the storm. And then we make reference to a 90s rap star late in the show. So wait for it. Great episode. Dave Johnson from Foresight. Thanks. Okay, welcome to the Healthstorm. I have Dave Johnson. He's the founder and CEO of Foresight Health. Dave, thanks for doing this. Really appreciate it.
Well, thank you for inviting me. Really looking forward to our conversation.
Yeah, I think it's going to be fun. So just for the audience, give a quick background. You have a really interesting sort of career trajectory, not that common pathway. So talk to me about what you were doing prior to your current Foresight Health job, and then what brought you there.
Yeah, you're right that I have an unusual background. Steve Jobs gave a commencement speech at Stanford in 2011 where he said the dots in life connect in retrospect. You do what you think is the best thing in the moment, and that maybe it makes sense when you can look back. And that's certainly my story. I mean, I started off as a English literature major in college with a minor in philosophy and religion, and then became a language arts Peace Corps volunteer in West Africa and loved that. Thought that I wanted to make a career out of international development work, but needed some skills. So I went back to Harvard Kennedy School and got a degree in public policy. And kind of amazing in retrospect is I ended up signing up for one of the most quantitative programs in the country that you can imagine. It was 75 people and 80% were either economics or math majors. And I hadn't had a math class since high school. Now it was calculus. I was good at it. So I got an intense education. It was almost like learning new languages in economics, econometrics, analytic modeling, and so on. And it turned out I really liked that, in addition to the public policy training. And went from there into government for a while. I was a U.S. presidential management intern. And my last job was CFO on the first ferry that ran from New Jersey to Manhattan by the World Trade Center, formerly by the World Trade Center. But I always had this idea that it'd be interesting to get into to finance. So I ended up shifting over and going to Bear Stearns, may they rest in peace, as a healthcare investment banker, and then had this very long and successful investment banking career, working with nonprofit health systems, 30 billion and debt issues, M&A, and so on. And nobody would have been more surprised than my own 25-year-old self at what I ended up doing for a living. So after that, 6 years ago, I sort of was done with transaction work, had come to the conclusion my clients were a big part of the problem in healthcare, and I wanted to write about it. And so I launched Foresight Health, which is a kind of a media company, thought leadership, content creation, and media company. And we've been at that for 6 years. I've written a couple of books and so on. And what I can tell you, when I was leaving banking and going into whatever was next, I had a coach who encouraged me to write a book. I fought him on it, but eventually came around to his way of thinking. And but then I asked myself, why would anybody read anything I have to say about healthcare? A lot of really, really smart people. And I actually decided this eclectic background that I have, literature, Peace Corps, public policy, investment banking, that maybe healthcare is so big and so complex, they actually need some combination of literary sensibility, cultural sensitivity, public policy acumen, and market knowledge to really get a handle on healthcare. And I do find in my writing and that of the team, that we will approach healthcare from any one of those 4 different prisms. So we could be writing something on, pick a topic, urgent care centers, and there might be a quote from Thoreau in there or something like that. So,
yeah, I mean, I certainly agree that it requires sort of a systems approach because it's so intertwined, right? That it's not just one discrete thing. You have to understand all the different pieces in order to make a difference.
Well, and it's so big too, Vic. I find that many people really have a hard time getting outside their particular part of the ecosystem. If you're in pharma, it's hard to think about anything but pharma, or if you're in the hospital space, or you're in the insurance space, or the device space, or regulatory space. I mean, people get very deep into their particular wedge of the industry, but it's a little like the story about the blind man and the elephant. I think it's hard for them to step back and see the whole picture.
Yeah.
And that's what we try to do, is to have a kind of a comprehensive view of the industry, and hopefully, because of the different perspectives and the big picture, and the ability to make connections, have insights that others might not see, obviously, at first.
Yeah, excellent. Well, as you know, this is called the Health Storm. I've been kind of thinking about and watching 4 different emerging trends probably for a year or so, and last fall started seeing them kind of converging together and began experimenting with, and ultimately started publishing written and videos about this health storm, which is the 4 things coming together. COVID has really accelerated that. So my thesis is that these trends have been in place previously, but that the outbreak has really catalyzed all of this change to happen more quickly. And so those 4 things are that the rise of the consumer, so individuals kind of paying more attention and trying to grab control of their own health, their own care, not simply relying on the man in the white coat to tell them kind of what to do. Technology sort of enabling more efficiency, more convenience, more, earlier diagnostics in lots of different ways, sort of impacting health, the availability of health, and the convenience and efficiency of health. Kind of the decomposition of the hospital. It used to be that the physical building called a hospital is where all the care was done. And I see that as breaking down. And care is now migrating out to the suburbs and to the home. It started a little bit at a time with ambulatory surgery centers in the late 80s and 90s, and now you're getting more and more care propagating away from the center of the hospital. And then market entry. There's new, very large corporations that now are jumping into healthcare that were not traditionally thought of as healthcare players. So Walmart is now operating clinics, and Google is doing an EMR play, and Apple and Amazon they're all kind of jumping into healthcare, which is exciting because they're gonna shake things up. But it's also, as an incumbent, it may be a little bit threatening or scary to see these big companies that know branding and they have large balance sheets coming into the healthcare space. And so that's now, I'm sort of trying to brand that the health storm, with the idea that it's going to be very disruptive, like a hurricane is disruptive to a city. But that in the end, that's healthy. It creates space for new businesses and new approaches to emerge that might be better in the long run. So that's the thesis. I know your work, and I want to talk about your books in a minute, but tell me about your perspective of these drivers. Do you see them as being real? Are they here now? Are they coming in the future? What's your perspective on it?
Yeah, I like all of these drivers. One I might add would be pro-market regulatory reform.
Yeah. Okay.
You know, but for COVID, some of the biggest stories in healthcare in 2020 would be the putting into place new interoperability regulations that are really trying to liberate data and let it flow to where it needs to be. The site neutrality regs that basically say, you know, hospitals can't charge more in a hospital for a service than they would in an ambulatory center. Some of the transparency initiatives on pricing and so on. So we do need the sort of the level field competition, the pro-market regulatory reform, and as an industry, healthcare is remarkably effective at, and has been for decades, at not allowing market forces and new competitors to emerge. And we should probably talk a little bit about that. But I agree with the thesis that the industry was under enormous pressure before COVID hit to deliver on value-based care. We've been at it for over 10 years, and quite honestly, pathetic performance. Really, you know, costs have continued to rise despite the ACOs and all the other alphabet soup of payment programs. There's a group called Choosing Wisely, which are all the specialty societies, and 80 of them came together and identified 600 plus procedures that should never happen. So unnecessary care, low value care. Health Affairs did a 5-year study last year and concluded that there'd been no change in physician behaviors despite this huge investment in identifying unnecessary care and so on. So these forces of change are up against a mighty industry that knows how to play the game and has been remarkably effective over the years at resisting this type of value-based, bottom-up driven disruption that you're describing. The only, and maybe this will put some context for when we get into the book discussion, I think what people have a hard time understanding is how artificial the healthcare marketplace is. So back when President Johnson, no relationship, pushed through the creation of Medicare and Medicaid in 1965.
Right, which is 55 years ago.
Yeah, right. To placate opposition from the American Medical Association and others who were fighting against socialization of medicine, the government agreed to two things. The first, everybody knows it, which is cost plus reimbursement, which is migrated into what we call fee-for-service, and is still probably the way 85 to 90% of healthcare gets paid today is through transaction-specific fee-for-service payment. And then the second was no governmental interference in medical decision-making. So basically, as long as a physician deems something appropriate, which is an incredibly wide standard, the government had to pay for it. And because of that, commercial industry or commercial insurance followed suit. And we've had now 50 plus years of this, what I would call supply-driven demand marketplace. Most markets don't operate that way. There's some level of intrinsic demand, and supply goes up or down in accordance with price. In healthcare, the best predictor for any procedure, let's say cardiac procedure, is not demographics, it's not lifestyle, it's not environmental conditions. It's literally the number of cardiologists in the market.
How many surgeons? I mean, how many physicians are doing that procedure?
Yeah, they create. Yeah, they create their own demand, and as a result, we've got 50 plus years of this, and probably as much of a third of what we spend on healthcare isn't necessary because the machine is essentially feeding itself. I used to joke that healthcare is the only business I know of that doesn't need customers. I mean, you or I go to the doctor tells us what to do, we do it, and then somebody else pays for it. It severs the buy-sell communication that occurs in all other markets. So just in the context of your forces, what this really is the marketplace trying to overcome this artificial economic model that is entrenched in the United States when it comes to healthcare delivery. And it's very hard to do. You mentioned a couple of big names, Google among others, but Google, Microsoft have lost billions trying to do logical things because they run into resistance from incumbents. So we're really at a point where we're spending far more than we should for healthcare outcomes that are actually relative to other high-income countries are terrible. And so the question is, will we rise to the challenge of fixing it, which fundamentally means downsizing our acute care footprint while investing in very logical things related to primary care, health promotion, chronic disease management, behavioral health, getting that formula right, and then allowing innovation, a lot of which you're focused on, to come in and turbocharge all these efforts.
Yeah.
If we can
so I want to,
yeah,
I completely agree that that's where it needs to go.
Yeah.
I want your impression of like the path to get there. And so it strikes me that COVID itself and the treatment of COVID in all these hospitals and the preparation for that, whether they had a ton of patients or a few patients, every hospital has been, the front line for COVID treatment. Yeah. And yet simultaneously, it has created significant financial pressure on the hospitals and health systems. And so I want your impression, but it strikes me that this might be a window of time when there is an opportunity to draw some change out, that there's going to be a need to support some number of hospitals, but I don't know if we need 5,000 hospitals. And so might we rethink our capacity and try to restructure incentives in the right way?
Oh boy, that's a deep topic. Well, first let me talk about COVID and the impact on hospitals. Yeah. And COVID, as we've now discovered, is a bit like whack-a-mole, right? It was in New York and then in the East Coast and got it under control, and then it pops up in other areas. And so it stresses components of the delivery system idiosyncratically. It doesn't happen all at once. What did happen all at once, and is what caused such consternation in the industry, is that the country basically shut down elective surgeries for a 2 or 3 month period of time. And it really exposed the extent to which providers depend upon these transactions to sustain themselves financially. And quite honestly, as I'm talking to health system executives around the country, there are some, and I really admire them, that see all of this disruption as an opportunity to rethink business models, embrace consumerism, think about becoming more asset light, getting out into the community, getting into the home, really becoming a partner in health. But most are really just scrambling to get their volume back. That's where the energy is going. Now, having said that, a few things, kind of were interesting. I mean, I was telemedicine, virtual care had been, I think, suppressed for several years.
Intentionally suppressed.
Right.
Patients want it. The paid community want, employers or insurance companies want it.
Yeah. And suddenly there was such demand, particularly for COVID screening, that we went from 0 to 60 almost overnight. In a 3 or 4 week period, we saw virtual care increase in demand and for virtual care increase in orders of magnitude. Really saw almost probably 5 years of adoption in a 3 year or a 3 week period of time.
And I've been saying that you're not going to put the toothpaste back in the tube. Like once that is out there, and I've had the experience. I don't want to go back to always in-person procedures.
Yeah. Now, one of the things that catalyzed the growth was CMS, the government, saying they would pay for a virtual visit the same way they pay for an in-person visit, which is crazy, right? It's a fraction of the cost to do it virtually as opposed to in-person. And they were paying for, and there have been some real innovations in asynchronous where, logic trains interact with consumers to get you a point where a human being can come in for precise interaction. And an 18-minute telemedicine visit turns out to be 2 minutes, right? So, part of what spurred it was the providers getting paid and then saying, okay, well, we're going to do this. So the question is, if an in-person visit should cost a lot more than a virtual visit, how do we begin to get sort of supply and demand to align properly there? And that kind of gets me to my last point, and then we can see where you want to go next. But I don't think we're going to fundamentally change the way we deliver care in this country until we change the way we pay for it, which means putting a stake in the heart of fee-for-service medicine and shifting as fast and as we can to various types of full risk contracting, full risk bundles for episodic care. If you need your hip replaced, you should know in advance how much that's going to cost, just like if you're going to get your bumper repaired. And then on the population health side, capitation, so where in exchange for a regular monthly payment, a health company takes responsibility for the totality of care and the outcomes associated with that care. And until we do that, until we move from this transactional way of paying for things to shifting risk onto the payers and the providers and their networks, we're not going to fundamentally align the interests of patients with what the marketplace itself is delivering. So I think COVID has made all of this even more apparent than it was before. The shocking health disparities we have in this country, how COVID has mowed through low-income inner-city neighborhoods, what it's done in nursing homes. It's just shown how fragmented, unequal, disconnected, and ineffective our current system is. So I would hope that when we kind of relax from COVID a little bit and are thinking about reform, we don't say, well, we want it to go back the way it was, because the way it was horrible.
Yeah, so I live in Nashville, right? So one of the centers for large for-profit health chains, and I will say, just because I think it's apparently obvious that the only endpoint is full value-based care. Like, there is no other place we go. The only question is, how long will we delay in getting there, and how much money will we waste while we're messing around with other trials? But there's a lot of lobbying power in the incumbents, and so they may try to resist that. What I was thinking about around
no may about this. I mean, that the type of reform you're talking about will only come over the collective dead body of the incumbent businessman.
Right. Yeah. So, but what's interesting about COVID is the payers are emerging as very strong, right? So the insurance community is benefiting in a perverse way. They're benefiting from this because they're not having to pay for these elective procedures. So we're emerging from COVID with the hospital industry suffering, and the payers have excess capacity from a capital point of view, and so I'm starting to see strategic moves from Aetna and United and big payers. So I don't know if you saw, but of course Aetna and CVS have merged. That Aetna is now offering, they call it something else, but a narrow network where they pay much better and you have much better coverage if you sort of use the CVS centers and their preferred doctors. And I think that may be enough choice to then make it at least challenging to lobby around. I mean, I can get all this service here, and it's pretty good quality. It's less scary than for politicians to sort of agree that we should go this way.
Yeah, really, and Optum, which is the United company, is basically their care delivery arm.
I mean, they employ more physicians than any hospital out there.
Right, and what all of these new models have in common are they're asset light and consumer focused and digitally enabled. But the asset light part is really important. I tend to think of healthcare as a fairly mature industry from a service perspective. So 80 to 90% of the reasons people would interact with the health system, we kind of know what to do when they present themselves. You got another 10, 15% that's really complicated and needs, solution shop kind of care. But that other industries, when they're that mature from a service perspective, decentralize for some very logical reasons. One is to reduce costs. If you know what 85 to 90% of what you're going to do, you're by definition doing a commodity, providing a commodity service.
You specialize and you standardize.
Right? Yeah, specialize, you standardize, you decentralize, lower costs, focus on outcomes, and then you try to get closer to customers and improve customer experience. So, and you're certainly seeing a lot of that. You referenced it in your storm, the forces behind the health storm. Everything from ambulatory centers to home health to digital devices to some of these new millennial-driven companies that are 24/7 and to address a specific need. But you're also seeing a doubling down on the old model of large health systems, particularly academic medical centers, investing in very expensive patient towers, billion-dollar plus investments. So doubling down on the high-cost centralized model, which has been the cornerstone of American healthcare really for the last 50, 60 years. And so so while I believe the industry is mature from a service perspective, I think it's immature from an organizational perspective, that it still has a strong preference for these centralized high-cost models. And that's the artificial nature, again, of the marketplace and the way we've paid for services and so on. So that's why it's such a wicked problem, because what we need to do as a country is downsize our investment in this massively overbuilt acute care infrastructure while simultaneously investing in frontline defenses and technology innovation and so on. And in the process, we're going to kill a lot of sacred cows. Now, I happen to believe that sacred cow makes the best hamburger.
Yeah, they should be killed. That's right.
Just this week, the American Hospital Association announced it was going to take the Trump administration to court after they lost at the appellate level with the small group of judges who are going to now go to the next level to challenge the site neutrality regulation in place. And so basically they're arguing that they should be able to charge 10 grand for an MRI in an ambulatory center, even if you can go around the corner and get it for $500, because that's what they would charge in a hospital. And I think that's remarkably short-sighted thinking, but it reflects this sort of immature structure that, it's a hospital-based mentality. And so I think in the long run, as these things become more and more transparent, and that's where the Googles and the CVSs of the world are coming from, that if an MRI is going to cost $500, the market will coalesce around that price point, and you won't be able to charge $500 you'll not only not be able to charge more than 500 in an ambulatory center, you won't be able to charge more than that in a hospital. So I've been encouraging these companies, these hospital systems, to start getting ahead of the curve and realize that at some point they're not going to be able to get premium prices for doing commodity things. And that's the essence of the storm that you're talking about. It's this confrontation between market and medicine, this what the market would drive in terms of value toward how medicine has protected its franchise to some extent.
Yeah, I mean that's exactly right. And I want to get to your book because you have a new book out. You have the Market versus Medicine, but that's old book. So the new book is The Consumer Revolution in Healthcare, delivering kinder, smarter, and affordable care for all. And I'll put in the notes. People can get it on Amazon.
Yep. Or our website. We prefer people go to our website because Amazon's greedy.
Okay. Yes. Okay. So what's the website where they should go? Let's just put it right here.
www.foresighthealth.com, and it's Foresight with the number 4, or as my nephew goes, Foresight.
Number 4, SIGHT. So Consumer Resolution in Health, and if they go to Foresight.com, ForesightHealth.com, they'll find it. I love the premise, which is to sort of empower this army of consumers to take action for their own best interests, and in doing so, drive change. So it strikes me that's kind of the American way. That's sort of what America is built on.
And there's a lot of American history in the book because, well, actually, the title is The Customer Revolution in Healthcare, delivering kinder, smarter, affordable care for all. But it's interesting that you said consumer, Vic, because we debated within our team at the company, should it be consumer or customer? Because in most places, those are one and the same. But today in America, if you define customer as the organization that is paying for the care and designing how it's received, the customers are largely governments and large self-insured employers. You see more and more consumerism creep in, partly because of high deductibles, partly because of things like Medicare Advantage, which in some markets actually offer real choice and consumers can put their stamp on the marketplace. So we spent a lot of time thinking about that. And we also use the word revolution intentionally. We've been at incremental reform of the system forever without a lot to show for it, like we talked about earlier. So I'm fundamentally of the belief that we need revolutionary change. And so the book divides into 3 sections. It's why do we need a revolution? Pretty easy case to make, and your audience probably gets that. But it's not enough just to need it. You actually also have to be able to win it. And so I identified, you have your 4 forces. I had my 3, and I call them force multipliers, and they are empowered buyers. So customers demanding more value for the healthcare that they purchase. And over time, I hope that becomes more consumers, but early on, it needs to be government and self-insured employers. And, McDonald's is experimenting with kale salads, not because it doesn't want to sell you more burgers. It's that their marketplace is demanding healthier alternatives. So demand-driven change, superhero results. So if we can get customers to demand more value from the system, just like consumers demanding virtual care during COVID, that will fundamentally change supply-demand relationship. So that's force number 1. Force number 2 is liberated data. Data wants to be free and free-flowing. It wants to go where it can be the most help. And one of the things just appalls me is the extent to which we've allowed big companies to trap basic patient information at the patient record level and treat it as proprietary. So what the new interoperability regs do, and it's a start, and it will gain momentum over time, is to allow access to this basic patient data to innovative companies through APIs and others, so that they can start to build the apps and the systems and new analytics to really turbocharge this. And if you put that together with 5G, which is right around the corner, which will take, under 4G, each connection can accommodate thousands of users. Under 5G, that goes from thousands to millions. So we'll literally everything will be talking to each other, and latency drops down to virtually zero. So being able to do surgery in California, perform it remotely in California on somebody in Chicago, I believe will become routine. So that liberated data together with what's revolutionizing society in terms of the tech revolution overall is a second force. And then the third is the one I mentioned earlier, which is this pro-market as opposed to pro-business regulatory environment. Healthcare is 4 of the top 12 contributors in terms of lobbying at the federal level. And if you go down to the state houses and so on, it dwarfs. So the healthcare industry gets a bigger return walking the halls of Congress and state houses than it does in the marketplace.
Right.
So we need the regulatory bodies to do what they should be doing, which is first protect us as consumers, but then secondly, create the type of level field competitive environment that will allow innovative companies to emerge and succeed. And I believe that
we can make a public safety issue, kind of like, sort of like in telecommunications, where like my cell phone has to be able to interoperate with your cell phone, because we need to be able to call one another. I may need to be able to call for help. And it would be unacceptable to have siloed telecommunications networks. We couldn't stand for it. It wouldn't be safe. I think healthcare needs to be viewed the same way. Like my data needs to be sort of unencumbered and be able to flow to the
absolutely. And we, relative to other high income countries, we injure and kill far more people because our data is fragmented, because we don't coordinate care. It's definitely a public safety issue. And, the idea that the healthcare industrial complex is acting for our collective benefit rather than its own is naive. It will continue to organizations will continue to do the things that give them market leverage and induce higher revenues and profits. So, so I believe those 3 forces and components of them are sort of in what you're describing as a health storm, kind of compound and work together, and I believe can be strong enough to overcome this healthcare industrial complex, which I spent a lot of time describing at the beginning of the book. Right. And then the last part is revolutionary healthcare, what that looks like, from new market entrants, from revolutionary incumbents who sort of get the message or changing. And then the last chapter, and the subtitle is Kinder, Smarter, Affordable Care for All. And I believe everyone in the United States, we're a rich country, everybody should have access to affordable health insurance and appropriate and accessible healthcare services. I believe that should occur through a pluralistic model, not through a top-down government Medicare for all type of thing. And so I spent some time sort of talking about how that could work. But in Massachusetts, for example, where we had the first public exchange, they've gotten to 98% enrollment, or 98% of the population has health insurance. So they're very close to universal through this pluralistic model. And there's no reason the rest of the country can't do that either. And that, to me, if we do it in the right way, as the rest of the world spends more and more on healthcare, we'll actually start to spend less, and that will free up enormous resources to pay people more money, to invest in productive industries, to make the investments in infrastructure and education and so on that will make our country stronger.
Yeah. So I mean, I that's why I love the book, is like the blowing up the healthcare industrial complex, like this complex of health systems and other groups that are looking out for their own best interests,
Yeah.
and designing regulatory hurdles to keep new innovations from coming to market, that has to be blown up, right? And so that's what I mean by the storm coming through and like knocking over things.
Yeah.
It will be painful for there's a lot of people that work in that complex, but it's not a public good. And then that allows us to liberate data and empower the consumers or customers, and bring this kinder, smarter, more affordable care that is much better all around. It's less expensive and it's more effective. That's the aspirational. Like, we don't want to just blow it up to blow it up, although that will be kind of fun. It's also because we need to do that to get to the promised land, to get to this new thing.
Yeah. Well, I mean, just to show you the way things are, I read this report that came out maybe 2 months ago by the American Hospital Association that was looking at hospital margins. And they said, before COVID, margins were 3.5%. In the second quarter, they were at -3%. And that's bad enough, but they would have been at -15% if it hadn't been for all the government funding. And they said, absent more government funding into hospitals, the margins for the second half of the year would be -7%. And that was a pretext for the American Hospital, or the logic that the American Hospital Association was using to say we should put another $100 billion into hospitals for stimulus to help them overcome this.
Yeah.
And so, wait, just let me finish the story. Yeah. So that came out. That came out a couple of months ago. The very next day, HCA in Nashville announced earnings, and they absolutely crushed it in the second quarter.
Yeah.
And a lot of that had to do with their share of the stimulus money. But I could actually hear the cursing in the HA headquarters, right? Because what all of this stimulus and all the excess funding is doing is really creating bad habits inside many of these provider and payer networks. And we, the people, pay the price for it. There was some thing from Politico earlier this week that said a doctor that worked for a freestanding ER clinic in Texas went in to get a COVID antibody test, which he administers all the time. And the raw materials for that test are $8. Anyway, they took his insurance information, and he ended up paying over $10,000, or his insurance company ended up paying over $10,000 for a COVID antibody test.
Yeah.
And it just shows you the level of profiteering that occurs, and it's not technically legal. It's immoral, but it's not technically legal. So we got to get rid of all that crap. I mean,
yeah.
There it is.
Okay, so people need to buy the book, but then what do they do next? Like, how do we go about what's the next step?
Well, the other thing, if you go to our website, it's not enough, as you know, to write a book or produce content. You also got to feed an audience consistently. So we have an enormous amount of content, so you can sign up to receive our newsletters and the different writers and so on. And what we all have in common, and we have quite a few writers now on the site, is this passion for trying to fix a very broken system in logical ways and use the market in the way it should for what it does better in terms of allocating resources, but then also requiring our government to do what it should do in terms of protecting us and creating a level playing field. It's not all government, or it's not all market. It's blended. And I think I'd add a third pillar in there, which is communities, helping them think about how to create more or healthier and living environments, stimulate well-being, and so on. So you can do that, and become one of the revolutionaries. And I think people just need to wake up a little bit and start demanding more value out of the system. Don't necessarily accept at face value what your provider or insurance company or whoever is feeding you, and explore your alternatives, because ultimately I do believe demand-driven change is the most powerful form of change in human existence, and that's what it's going to take to kind of topple this healthcare industrial complex that's so mammoth right now that it's almost 20% of our economy.
Yeah. So I agree. I mean, I think COVID has been really damaging from a public health point of view, from an economic point of view, from a job point of view, from a confidence point of view. And so it's been a hard year, right? But I was on with someone last night, and sort of in difficult times, the opportunity for making an impact is exponentially more. So I think we owe it to ourselves, we owe it to our grandchildren to pay attention and really try to make a difference now. We've seen with the last 6 months how foundational health is to our society. Like without health, we don't have schools, we don't have restaurants, we don't have government, we don't have sports, we don't have anything. And so we need health, and there are recipes. You wrote a book on it. I have several publications. I have 102 entrepreneurs in my portfolio. There's lots of solutions of what to do. We just have to take action and begin implementing them.
Yeah, we kind of know what to do. It's how to get it done that's the challenge. Right. But I agree with you. I think we've experienced a Pearl Harbor-like event in our lifetimes. And we weren't ready for World War II when the Japanese struck Pearl Harbor. And we as a country came together and built the capacity that ultimately allowed us to win World War II. And it required a lot of sacrifice. But we did come together and we rose to the challenge. COVID has basically shut down our economy.
Yeah, and we weren't ready. I mean, it's clear we weren't ready.
And the disinvestment in public health, I used to be on the board of Harvard or on the board of overseers for Harvard Medical School, and so I would go there regularly, and I periodically would lecture at the School of Public Health, which was right next door. And if you want a kind of an image of American healthcare, Harvard Medical School is in this classical building with columns, and it's surrounded by massive investment in acute care infrastructure, the Brigham Hospital, the Dana-Farber Cancer Center, the Children's Hospital, the research facilities, billions and billions spent there. And next door at the School of Public Health,
in a basement or a kind of
it looks like it's concrete Soviet era architecture that like the floors don't meet and their buckets where water's dripping down. And I don't mean to demean the School of Public Health, an incredible institution, but just that picture of the gleaming buildings next to the somewhat disrespected public health school, and what it turns out.
I look at from a countrywide point of view, we spend about double what other countries spend on our health care system,
right?
And we have really bad outcomes. And we spend about half. It depends country by country. Some spend more than that, but ours is in general half of what other countries spend on public health.
Yeah.
And those things seem like they're probably related. Like if you invest in public health, which is a lot of preventative, a lot of infrastructure, a lot of food, and just kind of general blocking and tackling of the health safety systems, health infrastructure, then you don't have the chronic, really acute costs, and everyone is better off.
Well, there was a book. It was called The American Healthcare Paradox that Elizabeth Bradley and Lauren Taylor published probably 7-8 years ago, and it was trying to answer the question, why do we spend so much and have such crappy results relative to other high-income countries? And they, using OECD data, were able to kind of make the point you're talking about, which is if you look at healthcare spending and then social care spending, which would include public health, but also things like housing and maternal benefits and that type of thing.
Child care.
Yeah. The U.S. is an outlier on both. We way overspend on healthcare and we way underspend on social care. And when you put them together, we're about average. But the reason we underperform some other countries is we do a terrible job on the front end when it comes to prevention. And then we try to make up for it by, overinvestment in treatment on the back end. And anybody can tell you that preventing a surgery is better than having a surgery by the best surgeon in the best facility in the country. So we have dramatically underinvested in primary care, health promotion, disease management, behavioral health. And unless and until we give parity to the prevention side of the equation to defense, then all this money we're spending on offense isn't going to get us where we want to go.
But the healthcare industry, or what you call the healthcare industrial complex,
right,
doesn't make any money from the public health side. And so the lobbying efforts and the education or miseducation is slanted towards that acute care, come in and do the surgery, because that's where the revenue is. That's
where the bucks are. It's like that 90s rapper Ice-T used to say, don't hate the player, hate the game. It's a lousy game, right? I mean, it's just a terrible game. And that's why I believe in these full risk capitation contracts, because if we're paying a health company, to manage the care for a group of individuals, it's suddenly going to be very much in their interest to promote health and well-being, to do early diagnosis, to do as little acute care intervention as necessary when acute care is necessary, to do it in the most effective and efficient ways. We need to align the incentives of the health companies with what we as individuals and society want. Yeah. Right now they are diametrically.
If we're aligned, they will work to the same goal that we have.
Right.
When we're misaligned, obviously we're misaligned. So I love that you're quoting Ice-T. I think that's probably the peak of the Hellstorm videos.
Don't hate the player, hate the game. Well, there you go. My
really been good. I want to wrap with a final thought for you. You've been doing this for a while, I guess roughly since '86 or something. Talk to me about what you know now that you wish you could tell your younger self in '86. Like, what lessons have you learned that you wish you knew then?
Well, I'm actually would have patted my younger self on the back for having a generalist background, because I think being able to look at the world from multiple perspectives turns out to be a wonderful thing. It wasn't really what I was setting out to do when I was doing it, but I would do that. With regard to healthcare, it took me a long time to figure out why it was as screwed up as it was, and it would have been nice to have some understanding of that early on. We want to trust doctors. We want to trust our health insurance companies. We want to believe they have our best interests in mind, but they don't always. And I think having that knowledge earlier on might have steered me a little bit differently in my career. I ended up financing $30 billion of investment.
You're contributing to all these big buildings and things that we don't need.
I'm an enabler. So now I'm doing penance, trying to level set in the right way. So
Okay, great. Well, Dave Johnson, thank you for this. Give your website one more time so we can get the book and sign
it. It's www.foresight, so number 4, SIGHT health.com. www.foresightshealth.com. Foresight Health.
Great. Thanks for doing this. I really enjoyed it, and I hope the revolution is here. I think it is here or almost here. Yes.
Absolutely. Consider yourself a card-carrying member. We can go jump the barricades together. Take it down.
Excellent. All right, great. Thanks. Appreciate it. Have a good day.
Thank you.